Gestational diabetes mellitus. Yes. If diabetic female conceives, then it is known as overt diabetes or pre-gestational diabetes. In overt diabetes, the fasting blood sugar will be more than or equal to 126 mg per dl. RBS will be more than equal to 200 mg per dl, and HbA1c will be more than or equal to 6.5%. So it is just like any normal person getting diabetes. Coming to gestational diabetes mellitus, it occurs usually in a normoglycemic female. When she conceives and during pregnancy she becomes diabetic, then it is called gestational diabetes mellitus. Now, gestational diabetes occurs mainly due to insulin resistance, and it is maximum in 24 to 28 weeks. That is, the third trimester is the most common one, and it can also occur in second trimester, but it's never seen in first trimester. Now, any pregnant female that comes on the first antenatal visit, we do screening tests for blood sugar levels. If it is normal, then we repeat it after 24 weeks, that is between 24 to 28 weeks, that is 6 months onwards. We have there's another test that has been proposed, that is known as DIPSI, that is a single step test which is acting as both screening and diagnostic modality, which has both screening and diagnostic modality. It is 2 hours of oral GTT. So how we do it is, irrespective if the female has consumed a meal or not, we give 75 grams of oral glucose, and after 2 hours we withdraw blood sample. So here fasting is not needed. So how we interpret the result of OGTT is, if the value is more than is more than or equal to 140, then it is gestational diabetes, and if it is more than 200 or equal to 200, it is overt diabetes. Now, coming to problems with diabetic pregnancy that a female experiences is, first of all, fetal complications. Patient can end up in gross congenital anomalies. So especially in overt diabetes, because the blood sugar levels are high from the day one, so free radicals will be present from the day one, so that causes more congenital malformation in fetus in comparison to gestational diabetes, where the blood sugar is raised from 24 weeks. So free radicals are also formed from 24 week onwards. So organogenesis has already completed. Now coming to the second problem besides cross-genital anomalies are macrosomia. So here the mother is also having maternal hyperglycemia. Because of maternal hyperglycemia, fetal also will have hyperglycemia. So because of that, there is increased insulin production in the fetus, which will cause macrosomia. So macrosomia, here the fetus will have a weight of more than 4 kgs, equal to or more than 4 kgs, and it's mostly seen in male fetuses. So how we measure is, we can determine this in USG by abdominal circumference. Now third is, there is complaints of unexplained stillbirth. So there is, because of increased oxygen requirement by the fetus, there will be episodes of hypoxia which will lead to stillbirth. Now vaginal delivery can happen in macrosomia, but it is not indicated because of shoulder dystocia, and especially if the weight of the fetus is more than 4.5 kgs. Now coming, the next complication that can occur in a fetus is delayed lung maturity. So because of increased insulin in fetus, there will be decreased surfactant synthesis, and which will cause delayed lung maturation. So best test to detect lung maturity of fetus of diabetes mother is phosphatidylglycerol evaluation, that we even do for any respiratory distress syndrome. Next is IUGR, which is uncommon, and then we have unexplained stillbirth. Coming to neonatal complications, those were fetal complications. Coming to neonatal complications, neonate can have neonatal hypoglycemia because the fetus was in hyperglycemia. Now neonate can have hypoglycemia, hypocalcemia, hypokalemia, hypermagnesemia, respiratory distress syndrome, hyperviscosity syndrome, and hypertrophic cardiomyopathy. Maternal complications that can occur are increased chances of abortion, especially seen in overt diabetes, polyhydramnios. Because hyperglycemia is there, so fetus will produce more urine, so polyuria will occur, and it can also be due to neural tube defects. And polyhydramnios can also lead to preterm labor, premature rupture of membranes, postpartum hemorrhage, abruptio placenta. Abruptio placenta because of overextended uterus. An increased size of the placenta will cause increased chances of PIH. And increased chances of infection can happen. So it mostly asymptomatic bacteria or UTI. And increased type 2 diabetes in the mother in later stage of life. So how we manage is over diabetes. As soon as pregnancy diagnosis is made, especially after 2-hour OGTT more than 200, the patient is put on insulin. There's no role of diet modification or oral hypoglycemic drugs here. Coming to gestational diabetes, so what we do is we do DIPSI first. Here 2-hour GTT, if it is abnormal, that is more than 140, then we advise the patient for diet modification for 2 weeks. Even after 2 weeks, if when we again do 2-hour PP and it is less than 120, then if it is less than 120, then we'll continue with diet modification. But if it is more than 120, then we'll immediately start with insulin. So indication for insulin is over diabetic patient, 2-hour OGTT in first antenatal visit is more than 200, and gestational diabetes woman who was on a diabetic chart but her 2-hour PP value is again more than 120. So dose of insulin that we are giving is 0.7 to 1 international unit per kg. And oral hypoglycemic drugs are contraindicated in pregnancy except metformin and glyburide. So this usually we give to a patient who of GDM who refuses insulin. Now coming to the time of delivery, delivery should most preferably happen like induced. If induced, should be in early term period, that is between 37 to 38 weeks plus 6 days. It should never cross 40 weeks. And most appropriately 39 weeks. And mode of delivery can be vaginal delivery. It is C-section if the expected weight of the fetus is more than or equal to 4.5 kg. Now the insulin that we are using during pregnancy is regular insulin, short-acting, NPH insulin, long-acting at bedtime, or mixed-hour insulin.